Hello, this is Ken Williams, Medical Director for the Center for Emergency Medical Services at the Rhode Island Department of Health Center for EMS. We're going to talk about the 2024 Rhode Island EMS protocols and their update. This presentation will not review every single thing that's new in the protocols, so please review them carefully and make sure that you understand all of the updates yourself. If you have questions, contact the Center for EMS, your EMS agency training officer, or medical director. All right, let's get started. I don't have any financial disclosures. I do serve as the medical director for the Center of EMS at the Rhode Island Department of Health and as EMS Division Director for the Brown Department of Emergency Medicine. And I am on the board of directors at the National Registry of EMTs. I do get to see these protocols used from the other side because I also serve as medical director for a couple of EMS agencies in the state, including General Dynamics Electric Boat, Heli Service USA, and LifePact. So let's talk at the beginning about protocols in general. The protocols really delineate the scope of practice. They guide care for categories of patient presentations, and they standardize substituted judgment regarding various care decisions. This sounds kind of complicated, and if you have questions about what you see in the protocols, you have suggestions for updates or corrections, please get them to your leadership or to the Center for EMS at the Department of Health as soon as possible so that we can get those corrections in there. We do try to hold an annual cycle of protocol updates in Rhode Island. Sometimes things like COVID get in the way of that, but the idea is that we will look at the protocols and update them every year. So if you have suggestions, particularly suggestions backed up by literature or other information, please get them to us so they can be included in that cycle. So what is substituted judgment? Substituted judgment means that these protocols are standing orders. They're established by the Center for EMS and by the Ambulance Service Coordinating Advisory Board. And the protocols that we're talking about today went into effect November 1st of 2024 and will stay in effect until the next protocol update. They are mandatory for all EMS clinicians in the state and may not be altered except by the medical director in agreement with the Ambulance Service Coordinating Advisory Board. Substituted judgment means that a whole bunch of people, including all the members of the Ambulance Coordinating Board, people at the Department of Health, and many EMS clinicians have incorporated their thought process and their suggestions into these protocols. This is a team effort, and lots of those people deserve credit and praise for all of the effort that they put into getting these protocols together. They provide you with our best judgment, the team's best judgment, about how to best care for patients safely without putting yourself at risk or putting your patients at risk. But they are a flexible document, and as I said, they're updated every year. You may find a patient that doesn't really fit into one protocol. You could think of a patient like a middle-aged gentleman who's shot in the leg, but he's also diabetic, and when he's presenting to you, he's also complaining of chest pain. Well, can you put a tourniquet on his leg, check a blood sugar, and do a cardiogram? Well, those things come from 3 different protocols in Rhode Island, but yes, you can. Our protocol system is set up so that you can use multiple protocols to care for a single patient. But if you have questions or something doesn't quite fit, call medical control to get guidance. Some states format their protocols as flowcharts. This one on the screen now is from Arkansas for care of patients with myocardial infarction. In Rhode Island, we have a couple of flowcharts, but most of our protocols are based on text. In some places in the country, each clinician level has their own protocol book. So this one on the screen is for Delaware paramedics. In a lot of places, including Rhode Island, all the EMS provider levels are included in the same book. We think that this is a good system because it lets everyone know what everyone else can do for the patient and helps people work together and get mutual aid when it's indicated. The scopes of practice in our protocol book are delineated in part by colors. So there's a color chart for the 5 different levels of EMS clinicians that we license in Rhode Island: emergency medical responder, EMR, EMT, advanced EMT cardiac, and paramedic. So be sure that you're checking the color and the scope to make sure that the thing that is in the protocols is something that you are authorized to do with your license level. There is an effort across all of New England to try to standardize the protocols. And the state medical directors have been working on this for a number of years. We have partway made progress toward similarity in titles and appearance. This protocol is from New Hampshire, and you can kind of see similar colors and layout to what we're doing. So we're trying to make it so that an EMT who lives in Rhode Island can have a part-time job in Connecticut or Massachusetts and still understand the protocols. We're also working toward national standardization. In the National Association of State EMS Officials, Medical Directors Council has had this model EMS clinical guideline project going for a number of years now. The latest version came out in 2022, version 3, and these are guidelines. They are not protocols because they don't give specifics. They might say something like administer pain medication rather than give morphine. But they do have an interesting format. They start with the title, but also some other possible topics or names that might be used for that protocol. So we might think of a protocol called chest pain, but in some other places it might be called STEMI or cardiac or something like that. Then they talk about the goals of care. What is it we're trying to do for the patient with this particular protocol? How do patients present? What are the things that would suggest you should use this protocol, inclusion criteria, and what are things that say, no, don't use this protocol for that problem. We have a different protocol or a different way of handling it for this particular set of patients. And this could be age-related or condition-related or other reasons why there are exclusion criteria. Then it goes over the management and treatment, some things about patient safety, some notes or little extra tips, and then sections on quality improvement, performance, references, and some of them include sections on documentation. So the following things are suggested or required to be documented so that people can understand what you did for the patient. We are moving toward using this format in our protocols, and you'll see slow progress in that area. So this is an example of one of their guidelines. I don't expect you to be able to read the fine print, but to see how the outline works. So let's talk about the general layout and how our protocols are set up. And it may seem obvious if you've always been working in Rhode Island and always worked with our protocols, but there are lots of different ways protocols can be set up. So for example, our protocols, as I said before, include all of our provider levels. All the clinician levels are included in one protocol book. In general, the protocols progress in patient acuity and severity from mild to more severe as you move through the protocol. That means that if there's let's say, a patient with asthma who has a mild asthma attack, you start with a simpler treatment like administering albuterol or a nebulizer treatment. But if their asthma progresses or they're more severe, they're more advanced, more aggressive things you can do for them. Those are further down in the protocol. That's a conscious decision in protocol design to start with the simpler treatments, but you can skip over them if your patient is in severe distress. So recognize that the protocols are organized this way on purpose. Okay, so with that as an introduction, um, and I really urge you to get involved in the protocol process. It does take a lot of effort, and it is a team effort. So everyone in the state who works in EMS can be part of it. Come to the meetings, make suggestions, take a look at other states or other regions' protocols, and we all want to work together to make our protocols the best protocols that we can to take the best care of our patients and protect our clinicians and also provide safe and excellent patient care. Remember that this presentation does not include every update or every protocol, so you've got to really look through the new protocol book and make sure that you're caught up. So let's get started. So there are a couple places in this presentation where we've emphasized things. We've changed colors or made things bold or highlighted them. They're not going to be in the protocols that way necessarily. The idea was to point out where the changes and differences are in the protocols. So first of all, in general patient care, and this is a protocol that many areas are using, or a protocol with a similar name, routine patient care, care for every patient, general patient care, that sort of thing. These are the things that are expected of every patient. And there are some sections, for example, in documentation, where we have our documentation section. One of the things that we've added is that cardiogram and end-tidal CO2 tracings must be uploaded electronically from your monitor into the patient care record. Obviously, if you don't have an indication for a cardiogram, you don't need to upload it. But these are the things that are different in the general patient care section. So please upload all your tracings. If you get a patient to a healthcare facility, you need to get a transfer of care signature. And there are some rules about how photographs that you take, for example, of a car crash or a rash or a laceration, can become part of the patient's medical record, but we want to protect the patient's privacy as much as possible with those photographs. So really look at these general requirements very carefully. There are a lot of general patient care requirements that we put in one protocol so we don't have to repeat them at the top of every single protocol. Okay, stepping into the medical protocols. We have made a little bit of a change in the allergic reaction anaphylaxis protocol because older patients, and particularly in the elderly, Benadryl or diphenhydramine can have inappropriate or untoward side effects. So we're adding Zyrtec or cetirizine as an option for those patients. We've also added TXA as a possible treatment for non-allergic angioedema. So if you see angioedema that's not from an allergy, patients with hereditary angioedema, for example, TXA may be a useful treatment. A general theme that you will see in many of the changes is that we have decreased maximums and decreased initial doses of a lot of the controlled and potent medications that are in our protocols. So for example, in patient comfort, we have decreased the maximum dose of fentanyl from 100 to 50, and you can repeat that every 10 minutes to a maximum of 200. That's decreased from 300. This is a general theme that we've done throughout the protocol update because there have been incidences of patients getting too much medication and having untoward side effects. If you need to give the patient more, you can always call medical control and present your case and explain why you need to give the patient more. But the idea is to start low and slow, and in many of these cases, you can give an additional dose if it's indicated for the patient after you see what their response is to the first dose. But we're trying to avoid people being heavily dosed or even overdosed with some of these medications. So this is a theme that you will see throughout the protocols, but particularly the medical protocol patient comfort area is a place to look. Similarly, in behavioral emergencies, we've decreased the maximum of ketamine and decreased for both IM and IV because we were concerned about there being doses that are too high. There is now a intranasal formulation of glucagon, so we have allowed that as an option. It is available, and you can take a look at it at your service and decide if you want to get it as an option instead of intramuscular glucagon. We've added in ischemic stroke, paramedics authorized to now transport patients who have received tenecteplase or TNK. In the past, almost all stroke patients were treated with TPA if they got a thrombolytic, but now TNK has become the predominant medication used, so we've updated that. In 2.17, labor obstetric delivery and 2.19 obstetrical complications, we've added a couple of high risk factor definitions and made a special note that in patients who are pregnant, and this is a significant pregnancy, not the first trimester, but third trimester pregnancy, if they are in cardiac arrest, these are patients who can be rapidly transported with high quality CPR during transport to the emergency department because there is the possibility of perimortem C-section being performed in the ED. Obviously isn't going to happen in every case, but it's a possibility, and that may actually improve survival for the mother as well as for the baby. So that's an addition to those protocols. Again, going back to our medication theme, in 2.19 seizures, adult and pediatric, we've decreased the initial doses and the maximum doses a little bit of all the benzodiazepines mentioned here. We've added a couple of things in 2.22, adult and pediatric sepsis, to put them more in line with criteria that are used in the hospital for defining possible sepsis patients. So take a look at those criteria. They're updated a little bit and they're more consistent with what's used in the hospital. In 2.25, this protocol deals with a very politically charged situation, and the term excited delirium is now discouraged. It's fraught with political issues and maybe even legal issues. So we've now renamed it delirium with agitation, which is the preferred current term. And again, we decreased the dose and the maximum of ketamine if that is the proper drug to give for these patients. In the cardiac protocols, in 3.02, we've added some additional emphasis and suggestions on patients who might be having inferior posterior MI. And we have also changed the number of epinephrine doses that you give to patients in cardiac arrest. If there is a shockable rhythm, the maximum is 3 doses. So VF and VT, 3 doses of epinephrine appropriately timed during the resuscitation. And for non-shockable rhythms, 5 doses. This is supported by the literature. It's not yet in the ACLS standards, but it is supported by the medical literature. And the concern is that there is an optimal dose of epinephrine, and if you exceed that and give too much epinephrine, you can actually make it harder to resuscitate the patient. We've also added a section where if patients become conscious during CPR compressions, which is rare, but it happens, that we can sedate that patient with ketamine or midazolam. Again, keeping with the theme, 3.06. If we are going to be cardioverting a patient, we've decreased the ketamine dose, the starting dose for that. In section 4, on trauma and environmental toxicologic issues, we've made a point, a number of people who take blood thinners and fall without hitting their head can still have a significant hemorrhage. And so patients with a evidence of a traumatic brain injury should go to a level 1 trauma center. And you should be very careful with any patient who takes anticoagulants with any kind of trauma, even if they don't hit their head. So if they fall on their knees, if they fall on their back, if they fall in any way or have any kind of trauma, even if they don't hit their head, there is a significant risk of bleeding. So be careful with them. We've also expanded spinal precautions to include people without trauma. And this is kind of controversial, but there are conditions where people may have had a minor trauma that they don't recall that might have caused a hematoma around the spinal cord, or infection causing an abscess around the spinal cord that can cause the same kind of issues that you can get with trauma. These patients, if they're saying, look, every time I turn my head, I have severe pain in my neck and my arms have burning pain and my legs go numb, then even if that patient didn't have trauma, you should be very careful about moving their spine. So they should have spinal precautions. In 4.05, there's literature to suggest that ceftriaxone is a better antibiotic than cefazolin for open fractures, amputations, or grossly contaminated wounds. I know that shortly after we made this change, there was a ceftriaxone shortage, but it seems to be back in supply again. So go ahead and use ceftriaxone as an alternative to cefazolin in those open fractures, amputations, or very contaminated soft tissue wounds. In heat-related illness, we've been much more vigorous about pointing out the criteria for exertional heat stroke and really pushing the idea that these patients need to be cooled before transport. EMS can save this patient's life by cooling them rapidly at the scene. In planned events, this means setting up cooling stations. You can use kiddie pools, you can use body bags, you can use commercial things that are prepared for this, and you want to be using a rectal temperature and ice water. And this is a life-saving intervention. Please cool these patients before you transport them. It will take longer to get this sort of thing together at the hospital. And of course, you're not cooling during transport. A few ice packs in the axilla are not sufficient to cool these patients. They need to be immersed in ice water as quickly as possible. So if you recognize exertional heat stroke with a core body temperature over 104 Fahrenheit, with any kind of CNS dysfunction, confusion, altered mental status, seizure even, cool them as quickly as you can. We also changed the phone number, updated the phone number in 4.19 for nerve agent or organophosphate toxicity. In section 6, on special situations, we've broadened things out a little bit in the 6.03 for life-sustaining treatment, Comfort 1, and the MOLST forms. For patients who do have a written or electronic DNR order in their chart at a licensed healthcare facility, you can now honor that, even if they don't have a MOLST form present. And that came out of a number of situations where it just seemed the best thing to do for the patient. If there is a refusal of patient care or transport, you must document your evaluation of the patient, their refusal, and include in that documentation their capacity to make that decision and your evidence that they have capacity. They were alert and oriented. They were able to reflect back to me the consequences of not being transported. They offered a reasonable alternative, like they're going to go right to their doctor's office. But all of those things should be in documentation and patient refusals. Patient refusals are a very high-risk area for EMS. Many of the litigation situations involving EMS are in patients who are not transported, patients who refuse transport. And so your evaluation and your documentation for these patients needs to be very careful. If you have a high-risk refusal that you're concerned about, call medical control and get them involved in the situation. They can talk to the patient, they can give you advice, they can offer all kinds of other advice and support for you in those high-risk refusals. In 6.05, interfacility and non-emergent transport, we changed the classifications to be more plain language. So instead of class ABC, it's now BLS, ALS, paramedic, and critical care. So it's a little more clear which clinicians can take which patients. In 6.08, if at the end of an unsuccessful resuscitation at the scene led by a paramedic and meeting all the criteria in that protocol, and termination of resuscitation efforts occurs, the person writing the patient care report needs to be that paramedic. You can't pass it off to an EMT or other team member. If it was a paramedic-led resuscitation and you're using that protocol, then the paramedic needs to be the one writing that patient care report. In 6.10, we have added some abilities for other healthcare clinicians, EMS clinicians, to be able to administer some vaccinations as part of an approved program. Check with your agency and your service about this, but this is something that is very useful when we're trying to vaccinate a large number of people, to have EMS help with that. In section 7, procedure protocols, one of the things that we needed to add was, remember we were talking about indications and contraindications at the beginning. We've had some concerns about hemostatic dressings being packed into certain kinds of wounds. We don't want them deeply packed into abdomen, chest, neck, or open skull fracture wounds because of potential interior damage and complications. So you can use hemostatic dressings more toward the surface, but no deep packing into those areas. That's really it for the updates that we wanted to cover in this presentation. Again, remember to read the protocols in detail, appreciate all the hard work that has gone into making your protocols what they are, and that it goes into trying to keep them updated and caught up with not only the medicine, but also clarity and safety and the other aspects of a good set of protocols. It is a team effort to do this, and everyone on that team deserves credit for the quality of our protocols. We encourage you to become part of that team, to point out even minor issues like typos. If you see a dose error, any kind of thing that you see wrong with the protocols, tell somebody right away so that we can fix it and make the protocol system that is in the Department of Health website the most up-to-date and accurate, safest and best set of protocols that we can have. Thank you again for everything that you do. If you have questions, please talk to your service medical director, your service training officer, or the Center for EMS at the Department of Health. Thank you for your time and attention.